Hello, everyone, and welcome to the PAPERI Bright Mind series held in recognition of International Childhood Cancer Day 2026. This series brings together voices from different disciplines and regions to highlight how research, clinical practice, and health systems can work together to improve outcomes for children with cancer. I am Dr. Wafa Rashid, founder and chair of Pan African BGS Education and Research Initiative, PAPERI, and I will be your host for today's session. Today, we are honored to be joined by Dr. Yen-Lin Liu. Dr. Yen-Lin Liu is a board certified pediatric hematologist oncologist in Taipei, Taiwan. He completed the residency in pediatrics in 2008 and the fellowship in pediatric hematology oncology at National Taiwan University NTU Hospital in 2010. In his early career, Dr. Liu and colleagues studied positron emission tomography, PET imaging with 18F-FDG and 18F-FDOPA in neuroblastoma that distinguishes the cancer's genomic type and the treatment outcome. Since 2013, Dr. Liu joined the Taipei Medical University TMU healthcare system and currently serves as the Director of Pediatric Oncology at TMU Hospital. The Pediatric Cancer Program at TMU combines surgical, medical, diagnostic, and supportive services to provide tailored therapy for children with cancer and brain tumors. Dr. Liu's aim to develop innovative treatment for children with cancer through translational research, precision medicine, and early phase clinical trials. We are very grateful to have his perspective as part of ICCD 2026. Dr. Yen-Lin Liu, thank you very much for joining us today.
Thank you very much, Dr. Rashid, for your invitation. And just call me Yen-Lin. I'm very happy to be here, to be
Yen-Lin.
on your video, and also to be a part of the world to talk about the importance on this very important day, ICCD 2026.
Thank you very much. And now we will start discussion about clinical practice and the context. From your experience as a pediatric oncologist in Taiwan, what are the most pressing clinical challenges currently affecting childhood cancer care?
Thank you for the question. So Taiwan is a small island in East Asia, so that the population size is about 23 million, and the size of the country is about 36,000 square kilometer. So that it's a small island, but actually we have a lot of tall, very high mountains, so that people are living in most of the population lives in the western part of Taiwan. That's the most populous flat area. But in generally speaking, we do have a national health insurance system that can cover the most costs of pediatric cancer. We do have some very special peds cancer in East Asia. For example, germ cell tumor is relatively in higher incidence, and also the intracranial, the CNS germ cell tumor, we are also having maybe threefold higher than the Western societies. And also, we had more cases with hepatitis B in before, so that I am relatively old enough. I have seen poor children with hepatoma caused by chronic HBV infections. But nowadays, with the vaccination, so the hepatomas are much fewer. Oh, that's one of the features of our country, that we're getting fewer and fewer hepatoma due to the eradication of HPV from birth. So the pressing challenge for us is that we're an island country, and we do have a strong industry of, for example, you may have heard of Taiwan due to it by its, for example, the chip maker. Our colleagues in the electronics industry, they build a lot of the electronics for the world. But still, to support a national insurance that will require a lot of resources, and that will require a lot of I would say a lot of consensus by the adult world, through politics, through democracy. But still, we need a lot of consensus to put resources in, so that we are trying to we're trying to work harder on how to persuade more coverage, for example, for precision medicine, or maybe for some of the germline SNP detection. Currently, they are all not covered by the routine medical care, but actually they are becoming more and more routine in the modern medicine. So I would say that adapting to the rapidly changing medicine in pediatric cancer, especially in the field of germline precision medicine or cancer somatic precision medicine, and also in long-term follow-up in survivorship care. These will be the three major issues that we are trying to catch up in our country.
Oh, yeah. So you consider Taiwan is as one of the or can be classified as limited resources, you mean?
I mean, no, I mean, if we only calculate by income level, we probably cannot say we have limited resources. We are probably we're actually many of our people are already very privileged in the world. However, I think the difficulty. I mean, there are several famous studies in the world, for example, by Dr. Raul Rabiro in St. Jude and Dr. Scott Howard and Catherine Lam. They have some papers about for example, low middle, high middle, and high income countries. The 5-year survival rate of childhood cancer do not correlate to the total healthcare expenditure of the country. Although that correlation was very significant in lower income countries, but in middle and high income countries, actually each country will have its own issues that they need to solve in their own way. Yeah, so
Yes.
that in our setting, generally the people's income may be okay, but we still need something to have something to do. For example, in our pediatric cancer long-term survival rate, it's about 80% in the long run. But we are still aiming for, maybe in some countries in the world they already have 85. They already have somewhere at 80.
90%, yes.
Yeah, that's right. So that but maybe you also have the feeling that to push up that 1% or 2%, that will become harder and harder after you achieve some level, because that will not only be because the infrastructures, how to build up the infrastructure. There are many groups in the world who are working very hard on this, but also for example, we try not only to we try to save every children that should be cured by modern medicine. But meanwhile, there are some patients who maybe benefit from, you can say, future medicine, or maybe some slightly more advanced medicine, like the knowledge of precision medicine, or maybe the knowledge of avoiding a toxic usage of drug due to some germline pharmacogenetics or some germline features. That this kind of things that has not yet been totally adapted in our clinical practice. So that is something we try to help Taiwan from our practice to do. Yeah, so that in general, regarding the clinical parts, I would say that for example, our ALL have 89% of long-term survival rate. More recent statistics may have approached 90%, and but our solid tumors in the last 25 years after our national health insurance is launched, the survival rate actually, the overall survival rate of the solid tumor actually didn't change a lot over the last 25 years. So I would say that's one of our major challenges, is that how to find out for example, how to adapt the new therapies like GD2 antibody in neuroblastoma that fortunately has been gradually covered, but some of our leaders still need to talk a lot. We need to communicate a lot to the government, to the society, about why should we spend that much money for one drug, because that is so important for children with high-risk neuroblastoma, something like that. So this will, in our society, we need to do that through for example, a 3-level committee thing with the national leaders of the national insurance, so that in our system we are a single payer insurance system covering more than 90% of medical practice. especially for childhood cancer, and the so that will be a democracy, but also we need to have a process to having a new coverage of a new therapy or a new test into the national insurance. So in general, our government do not directly pay for the service, but they pay through the insurance system. And what kind of services should be included or should be covered in the medical system, medical insurance, that has to be discussed through these committees. So that's, I think that's one of the challenges our colleagues are trying to solve here, is how to persuade our system to adopt a more advanced treatment and also testing and knowledge.
Thank you for clarification. And my next question, so how do you see the balance between advanced treatment protocols and real-world visibility in pediatric oncology practice?
Yeah, that so that the in ours, yeah, like you, it's a very good question. That the treatment protocols adaptation, that will be very much dependent on the setting of each practice. So in our setting, we're a university hospital, and we're actually a private university hospital, but it is not for profit. Our university strive to provide a good medicine for people with diseases in Taiwan, so that we try to align our goal with our university and with our patients, and also so that for example for advanced treatment protocols, so that so that we try to adapt the advanced treatment when they are available. Like for example, GD2 antibody in neuroblastoma, we try to, currently they are covered in the first line setting. But if we got a case with if we got a child with relapsed refractory neuroblastoma, the family will need to try to raise a lot of money to solve the situation, because that's no longer covered, currently not yet covered by the national insurance. And so far, we do not have a clinical trial or something else that can cover the cost of using GD2 antibody in the setting of relapsed refractory neuroblastoma. So in that kind of situation, we will need to work with our social workers. We will need to find resources for the child to try to adapt this advanced treatment protocols. And another example would be CAR T therapy. That, for example, we only have several designated centers in our country that can perform CAR T, and our university hospital is not yet included in one of those centers, so that we will have to collaborate with our colleagues in other universities to treat patients who really need CAR T therapy. And we need to contact with them early, and so that we develop some ways of collaboration, like when to transfer the patient, and also more importantly, when to prepare the patient's condition, like when is the best timing of T cell number that you can harvest a T cell, and then when to do the transfer. And it's not just sending the patient there that's simple, because each hospital will have its waiting line, will have its there needs to be testings done before sending the patient to treatment. So that some tests have to be done in the local hospital, some needs to be done in the CAR T center. So these kind of things, this is also another example of how we try to adapt the advanced treatment protocol. So that I'll say, although we are a small island, our system, our people here demand a high level of convenience. We have more than 30 institutes who can treat childhood cancer on this island of 23 million population. But so that actually most of our programs are relatively small programs who may have somewhere between 2 to 5 pediatric oncology faculties. I believe this is relatively very small sized in the world, so that our programs are small, and people working very hard, treating maybe not so many patients. We have 500 new patients per year, treated by about 80 pediatric oncologists, so that in average, each doctor may see somewhere between 10 to 20 patients per year, maybe. So that we actually need a lot of collaboration. Different hospitals have different specialties, and we try to connect these hospitals through some inter-institutional efforts, So from the very early on, since about 1980s, we got a foundation called I think many countries have this kind of foundation. That's a Childhood Cancer Foundation established in Taiwan in 1980s. Initially starting with the financial aid to patients before the era of national health insurance coverage, but then also moving on to have a Taiwan Pediatric Oncology Group, to which is a consortium of physicians working together to develop standard of care chemotherapy protocols. So now we have about, I think, some 13 or 15 treatment protocols that are standard of care, and there are protocol PIs who needs to adapt the latest knowledge and to educate our colleagues to do how to treat each cancer appropriately. So these are our ways of doing the pediatric cancer treatment in here.
Yeah, this is perfect. Really amazing. You have
Yeah, yeah.
standardized protocols, national or each center, according to the PI, can, or the team or committee inside each center for
We would generally
standardized.
pre Yeah, we would generally prefer. I mean, the TPOG is actually not a is a non-government organization, so that it's totally volunteering. It's not mandatory. It's totally volunteer, up to the physician, up to the patient. But in general, we are a relatively collectivism culture. Our our doctors, our patients like to be treated in the way that most people are treated in the world, or in the or they want to know that how people are treated, and so that in general our doctors and our patients like to adopt the latest knowledge and try to be treated in the most common way of for each cancer type, so that if we have a standard protocol that we can follow, we will generally want to follow that protocol as possible. And sometimes, for example, if we see a very rare cancer like rhabdoid tumor, there may be, like, we have our own institutional protocol for rhabdoid cancer, rhabdoid tumors, but we try to collaborate with others and try to work on something new together. And also for some rarer, like spindle cell sarcoma with, say, untracked fusion, there's no protocol for that yet, but there are some relatively standard ways of how to treat that appropriately with targeted agents. So these are the other examples. And recently, we're trying to work more closely on brain tumors, because brain tumor requires the collaborative work from not only the pediatric oncologists, but also surgeons, radiation oncologists, and others, so that that's even more multidisciplinary, or needs multiple professionals, so that there are some senior surgeons in our center who have proposed to initiate a pediatric brain tumor consortium in Taiwan, so that through the brain tumor consortium, we have the platform to work with interdisciplinary specialties to develop. We currently have protocols for medulloblastoma and the CNS germ cell tumors. These are the two most common brain tumor in Taiwan, who requires multimodality treatment. And we're trying to develop something together for example, glioma and maybe some other brain tumor types gradually. So these are our current efforts in brain tumor, because previously we don't have so many brain tumor protocol, but we're trying to add that more and more since 2019.
This is great. Now let's move to another important issue in the pediatric cancer treatment: health system and the care delivery. What aspects of the health system in Taiwan most strongly support good outcomes for children with cancer?
Yeah. I think the basic care, I mean, I'll say the routine care, for example, in general, standard of care chemotherapy. Uh, for some political reason, Taiwan is not a formal member of the WHO due to some political reasons, as you know. But generally speaking, we try to be compliant. As I know, for example, the list of WHO essential drugs is about, initially it was 600, now it's maybe 1,200 or even more. But so that in so that most of those essential drugs, we try to make that available here, because we do have a pharma industry here to make generic drugs. But frankly speaking, many of the drugs are not so. We don't have. We are an island country, so that we cannot manufacture everything at home. We have to import from many different countries. so
Yes.
that so that our infrastructure built up by the government, by the industry for multiple
So,
decades, that help us to have a relatively stable supply of treatment, not only medicines but also medical devices and something equipment, or even, although it's not widely used in children, but like Da Vinci surgery equipment systems, those kind of things will be, so many of those are being gradually covered by the national health insurance, so that it's a against a single payer system covering more than, I think, more than 99% of the population. We, in our monthly salary, we do have to split apart, and our bosses need to split apart to pay to the national insurance to keep it working. So that I always say to the patient that national insurance is our money, so that we use that together to treat children properly. Yeah, so that, but that's also challenging because, as you may know, the East Asian societies are aging very fast. So for our total healthcare system, there's a big issue is about the aging related healthcare expenses. But in general, for childhood cancer, most of the standard of care, especially chemotherapy, are generally covered by our system. I think that's the good part of our system. But by contrast, if we want to add something newer, we will need to persuade our colleagues, our society through a democratic process. That will take some time.
yeah, this is very good, excellent. So, on the other hand, what do system level gaps, referral, pathway, access to medicine? You said there is support, but what about supportive care, long-term follow-up that most affected children with family and families?
That's right. I think each kind of system design will have some goods and bads. Like in our system, it's covered, but it's a pay for service system. So that in general, if the hospital and the physician do more, they will get more charges. They would get more reimbursement from the national health insurance. But so that it makes hospitals a little bit more reluctant to transfer patients to each other. They generally want to try to keep the patient when it's appropriate, or when it's for financial reasons. However, I think in our among our colleagues, pediatric oncologists, we when we meet the patients, when we see the young patients, when we meet the young parents, families, we generally don't think like that way. We will think that we should recommend the best possible way of care every day to the child, so that whenever we feel there's a need to transfer the child to somewhere else, or when we feel that there's a need to seek some kind of additional advanced therapy, we will recommend the best possible care to the parents generally. And in that way, when I'll say the gap for in our setting is that, like we said, discussed before, that many of the programs are smaller programs, and there are some barriers between transferring patients across medical hospital healthcare systems, so that sometimes, for example, if we want to transfer, we will need a lot of communication and discussion with, for example, a CAR-T center. I know in some settings in the world, they may have much fewer center numbers, so that everyone knows where to send the child to when they got childhood cancer. For example, one single center over a big area sees all childhood cancer for all types. That may be another way of solving this more efficiently. But in our system, because the system goal is to have some competition among healthcare systems, so that it's generally open to all healthcare system, and it will be a pay for service situation. So that also makes the programs relatively smaller. Uh, but also that provides some convenience to the patients. So that I will say the gap will be, sometimes the patients will be choosing. They actually don't know how to choose, but some families may prefer convenience or prefer a lower cost medication or lower cost treatment. But sometimes that will cause some problem of having the best possible care to the child.
So, this is for referral, but what about supportive care and
Yeah,
long-term
right.
follow-up?
Yeah, that's right. That's very good point. So for supportive care, for example, we generally have most of the medical parts, like for example, GCSF or blood products. We have a not for profit blood donation system. It's not including not only blood cells but also plasma are all not for profit. In our country, we do not have the pay for profit plasma or blood cell collection. All of those are non-profit non-profit. So that was organized by a blood foundation, and we are lucky that there are still many very kind-hearted people willing to donate their blood regularly. I also try to do that myself. And so those basic supportive care medicine, blood product, and some devices, they are generally okay as long as the import is okay. And however, from the psychosocial part, some basic services are supported, some are not yet. For example, if the child needs rehabilitation, that can be supported by the system, and that will be covered. And although with some out-of-pocket money, but that's generally affordable. But for like psychiatric consultation or for social workers, that will be covered by most of the hospitals. But for some advanced supportive care like music therapy, art therapy, or child life, currently these specialties they do not have a legally designated role in the medical services. There are people trying to persuade, but again, that will need a democratic discussion, and that will need a lot of those negotiations with the society, a lot of dialogue between the different levels of people. So that will take some time. So that in our hospital, for example, we do have very good colleagues trained abroad for music therapy and previously art therapy, and we work with them closely. So they were we generally tell them teachers because for kids they are like a teacher telling them to do, like we do music today, we do painting, or we make something, build something together today. But from working with them, I learned a lot actually, that they release the energy of the patient, the young patients, and also through those process of music and art therapy, the children improved a lot, and the relationship within the family dynamic also improves a lot. That's that's a very magic I see through the collaborations with our therapists. But so far, these very good services are not yet covered by our system, so we have to do some fundraising or something to support these activities. And for long-term follow-up, I work with my colleague whose name is Dr. Wan-Ling He. So Dr. Ho, she's the PI of our long-term follow-up clinic, and we have an American professor whose name is Dr. James Meiser. Dr. Meiser is previously an Ewing sarcoma expert in US CCG and COG, and after he retired, he had some connection with Taiwan, so he worked with us part-time a couple of months every year, and he have a deep connection with Taiwan, so we work closely together. He helped us to establish the featured services in our setting, and we help to promote long-term follow-up to have a national protocol together with TPOG back in 2020 during the first year of COVID. And people, to our surprise, the people in our Childhood Cancer Foundation, they are very, very supportive to have a to work on a protocol together, because I do think, for example, in most of the settings, our survival rate was approaching 80% at that point. So that I do think we badly need something for the survivors, because the previous treatment and also some of our current treatment are still having too much late effects that need to be mitigated, need to be managed during the process of long-term care. So some of those, like for example, bone marrow density, that can be covered for people who already have symptoms, but cannot be covered as a screening tool for people who are at risk for osteoporosis. So that will need some out-of-pocket payment every time, and that may cause some barrier to some families. So these are the things we are facing. That we have some of these aspects of supportive care that, and also of long-term follow-up modalities that are not yet covered by the system, so that site physician, the treating physician or the follow-up physician has to be very sensitive and very careful about these issues. And we still wish to recommend the best solution to the family and try to solve the financial part if that's a barrier. But also that will cost a lot of time and the communication and efforts. And sometimes still some families will still not choose not to accept those things. So that will be some barrier for us.
This is amazing. Okay, so now let's move to a very critical issue in pediatric cancer, multidisciplinary and collaborative care. How important is multidisciplinary collaboration, oncologists, nurses, pharmacists, public health experts, in improving pediatric oncology outcomes?
Yeah, I would say it should be always generally it should always be multidisciplinary. It doesn't mean that for everything we ask other people's idea every time, every sentence, but to have the multidisciplinary concept from the very beginning of taking care of a new patient or throughout the process of taking care of the child. That, for example, in the word, in the inpatient part, we and our surgeons and our radiation oncologists, if the patient needs to be admitted, we try to put them together in the same unit so that patients will see their surgeon, their radiation oncologist, or their oncologists frequently in the same unit. And people will be, it's like a habit to go there. You will see your child patient if you go to that unit. So that can help us to have some geological multidisciplinary care together. And our nurses will be more familiar with the care of pediatric cancer. And so in our world, sometimes we don't have many inpatients, so that we still have some non-oncology patients staying together in the same unit. But the nurses will be more familiar with pediatric diseases. And also sometimes, for example, in our setting, some of patients needs acute care, some are chronic illness patients, so that our nurses still need to deal with a diverse type of patient mixing. But generally speaking, to have their expertise accumulated, it will be quite helpful to work on the treatment, work on the care delivery together. And for our pharmacist, we do hope to have more clinical pharmacists, but so far in our setting, we have a very good clinical pharmacist who's in charge of, I think, a few hundreds of cancer patients, including adults and children, so that so far we cannot round with her every time, but we have the privilege to have some frequent talks with them, and they are very good in providing the consultation. It may not be good enough, but we try to work harder on these issues to build up the link, and also to have a timely discussion of the pharmacotherapy. And also our pharmacists will check each of the chemotherapy orders. And for public health, I have the privilege to work with excellent epidemiologists in my very early career before I went to this current institution, so that throughout the epidemiological studies, we learn more about the profile, the contour of the childhood cancer in
Yes.
Taiwan. And for example, Hep B is decreasing very fast, but also germ cell tumor is still one of the main issue in East Asia. And also our leukemia, lymphoma are increasing gradually. That's whatever statistics you use, you will see 1 to 2% of increase every year, like many of the industrialized world now. That this is a big issue. The cancer incidence rate is increasing. We even observed some solid tumor incidence was also increasing, although the birth rate was decreasing more rapidly, but still we have an increasing incidence rate, and that is something we should be careful with. So by working with public health experts, we have more of this knowledge. And also I like to say that for social workers and rehabilitation experts and also research assistant and research nurses, they also help a
Yes.
lot. Yeah, and one last thing
Nutrition
is about,
specialist.
yeah,
What
nutrition
about
specialists.
nutrition
You're right.
specialist?
That's right. Yeah. Dietitians. I do tried some some time of how to talk to dietitians, nutritionists, and they are very good. I mean, for example, currently our colleagues may ask the child to take a photo of what they eat for several days, and then they will examine the photo to discuss with them together of how to eat healthy, or how much calories they still need to add on, or oh, you should get more protein. Nah, not like this. You should try something more, something like that. And so I learned a lot from this communication. And lastly, I think actually the sedation part is also very important for pediatric procedures. Some painful procedures, we need to put the child into sleep, or non-painful procedure but require like an MRI, CT, or even radiation therapy or proton therapy. We have to keep the child staying still in the therapy table for 1 hour, 2 hours. So that will require the sedation services and even anesthesia. And these are also a very important part to work together.
It's amazing, really. So, what lessons from Taiwan's experience could be useful for other countries strengthening pediatric oncology services?
Thank you. It's a big question for a small
Yes.
country. Yeah, we're not totally sure about that, but for example, for an island country who's having some consensus of wanting to do a wide covering national health covering system. And we also have, for example, we are a single payer system, but about half of the hospitals are private, half of the hospitals are government owned. Some are academic, some are government hospitals. So that generally it's a mixture of different setting of hospitals, but using the same payer, the national insurance is the biggest payer in our system. So that I think each country will have its cultural context of how the system becomes what it is now. But I think our experience would help to share with the world is that although we are a small country, our system is actually quite decentralized, and we are having many small programs all over the island that can take care of the patient in a relatively convenient way. So that if you are interested in looking at how things can go in a decentralized system, welcome to have some talk together that we can share our knowledge and things. And also because we are many of the small group, many of the programs are relatively small in the world by scale, so that we do have to form a suprastructure to form an inter-institutional mechanism to work together. So this forced us to do collaborations because, for example, we have 500 new patients per year, and that may be the volume lesser than some of the big hospitals in the world. I know some hospitals may, for example, your children's hospital in Cairo, you may have maybe 1,000 or even more per year. Yeah, so that will be different settings. You are very centralized, very specialized hospital, and we are decentralized all over. And we will have to find a way to communicate and also to try to treat the patient in the hospital setting well with a small program, and also try to have a collaborative referral network that, for example, when a child needs clinical trial, needs more advanced protocols, they need to be transferred, and how to do that appropriately. So that I think that's the system here that can that make us into what we are now and how we do things now. And for this part of experience sharing in a relatively decentralized system, I think that's the experience Taiwan can share with the world. Sorry, I lose your vocal. Oh
Yes,
yeah.
okay.
Oh yeah.
Now, this is wonderful. Now, let's move to discussion global collaboration and learning. Based on your engagement with international forums such as the Childhood Leukemia International Consortium CLEC,
Mhm.
what
Yeah.
value do global collaborations bring to clinical practice at the national level?
Yeah. It's very important. Actually, I knew some people in Click many years ago, but the last year, 2025, is the first time I joined the Click meeting, which happened in Taiwan. Luckily, that I learned many people there and learn your research and studies. So that I think, for example, Click has its mission, as I know, that many researchers in Click are more focused in, for example, like the polygenic score that you are promoting in Africa, and also the germline variations that
Yes,
are related to the onset of cancer.
yes,
But I think not only to that, but Click is also moving forward to the, for example, germline characteristics of how to predict the cancer outcome, something like that. So that's a very big population-based approach to this issue, and I think that's very important. For doctors working in the hospitals, we are more familiar with doing cohort studies. We see patients, and then those patients become a cohort. We follow them, and then we try to provide different therapies and check the outcomes. And we try to be more advanced and check the outcome again, something like that. But so that the dialogue between population scientists and the cohort scientists are very important. We do cohort studies in hospitals, but when we work together, we can do larger scale cohort studies. But also we need to talk to the population scientists also, that there are some insights that needs different methodology to work on. So that's one of the interdisciplinary and also global collaborations value, is to help us understand the differences. For example, when I had some experience of working with some colleagues in St. Jude Global to work
yes.
on like abandonment to treatment, they want to do a meta-analysis. They need some helpers who can read and write Chinese letters to researchers in the Chinese literature, so that I help them to email interview researchers in China and do have some meta-analysis works published together, and also some review articles. So from those experience, I learned a lot, that the world is so big that the setting is actually quite different. So I like the word setting because it's a neutral word, and there are a lot of reasons why the setting is it like now, but it is practical to learn, to know what's the background, that setting provides the context and the background of how childhood cancer care is being delivered in that setting, and then we can talk about how to achieve the goal, because I think the goal for the teams, for every team in the world, is very similar, or even the same, that is to, for example, no child should die, and we hope to treat every child successfully, and not only survive the disease, but also to survive long and survive well with less and less late effects. So that this kind of international works help me and my colleagues. We know more about each other, and also know more about the settings, and know more about how they solve things properly. For example, I learned a lot. There are some colleagues in the world, they write very excellent articles about how to screen retinoblastomas early. Although in our setting, our retinoblastoma is relatively centralized to 2 or 3 centers that they are more specialized in treating the eye cancers. But also those experience help us to screen out the patients earlier, and try to, we have a colleague who is currently working with the National Health Promotion Bureau, trying to put something back to the general healthcare booklet for parents, because some of our colleagues are worrying that some of the retinoblastoma here are being diagnosed at a relatively later stage. What happened? Maybe people are forgetting the leukocoria warning sign. We should have some more awareness, even it's a modern era, but because the disease is not too rare for a 23 million population, we have about 100,000 newborns every year now. So you can calculate how many retinoblastoma you may see, maybe 5 or 10. So it's a bit, we don't want the disease to be forgotten. We hope to still have some awareness. So that's also the strategy we learned from our international collaborators, colleagues. Yeah. So I think all these experience helped us a lot, and all these are very inspiring stories for our medical students and nurse students to we try to attract more of them to go through childhood cancer.
Yeah. You are right. And you answered my next question, actually, that
Mhm.
how can clinicians contribute more effectively to
Yeah,
global childhood cancer efforts beyond research publications? Thank you so
yeah,
much. Now, this is the last question, two questions at the end of our session. On International Childhood Cancer Day, what's one priority action? you believe health systems should focus on to improve outcomes for children with cancer?
Thank you. I will say that to have a universal coverage of precision medicine activities for children with cancer, because it's now quite well established that precision medicine can fill the gap from 80% to a higher percent in the world.
Okay, this
Sorry.
is your, yeah. You are right. Completely, I agree with you. So, what message would you like to share with policymakers and the global partners? Let's start with policymaker about supporting clinicians delivering childhood cancer care. Then, global partners. What's your message to
Yeah,
them?
thank you. It's a big question. It's a big question with a global view. I would say in each setting, I through the international works, I love to know and to talk to our international friends who are working for pediatric cancer around the world, because the settings are sometimes quite different. That the goal is the same, but the context is different, so that the ways of doing things will be different. So that I would suggest policymakers to listen to the needs of them, because the needs will be quite different every time. And so listen is the first thing. And the second thing is to currently there's no more COVID is no longer a barrier, so that we should promote a more international exchange, or exchange of knowledge, or international meetings, international collaborations. If the policymakers can help, this will help a lot and make a lot of difference. Although that may require some different strategies in each setting, but through for example, twinning programs, or point-to-point twinning programs, or sometimes country to country, or sometimes a group of hospitals to another group of hospitals, or a group of doctors to another group of doctors. This kind of collaboration means a lot, that we can learn more through the interactions, and through the scientific discussions, and also even clinical discussions. Currently, we are trying to work with other Asian countries, like, for example, we have international students who are also physicians in their country. So we are working with our colleagues in Vietnam to discuss about, for example, brain tumor therapy, how we would do this in our setting. But we also learn a lot from them, that in their setting, sometimes there are some limitation in their setting, and we have some of our limitation in our setting, but how do we deal with it? And we think how to achieve the same goal is to try to cure the disease, and to keep the child healthy, healthy with less late effects whenever possible. So I would say listening and international collaborations are the two keys I'd like to suggest the policymakers to help to support pediatric oncology in the world.
Thank you very much, Dr. Yen-Lin Liu, for sharing your insights and the experience with us today. Your reflection highlights the importance of many aspects of childhood cancer in improving outcomes for children with cancer. We are very grateful for your contribution to the PAPERI Bright Mind series and to the global effort to improve childhood cancer care. To our audience, thank you very much for joining us as part of International Childhood Cancer Day 2026. We invite you to continue following the Bright Mind series as we share perspectives from across regions and disciplines. The conversation is part of the PAPERI Bright Mind series for International Childhood Cancer Day 2026. Thank you for watching, and we hope these discussions inspire continued collaboration and action for children with cancer worldwide. Thank you very much, Dr. Yan.
Thank you very much for the invitation and the talk.